Hi, my name is Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust, and I'm here to talk about the immediate and necessary care of lower limb wounds. Many of you will be aware of the National Wound Care Strategy programme, which got published now around 12 to 18 months ago. And actually, this highlights the need for change when we're dealing with patients with lower limb wounds. The National Wound Care Strategy highlights that there is a number of variations in the care that we deliver, and this provides the NHS an opportunity to reduce spend, an opportunity to reduce the burden, but also an opportunity to improve the management of patients and therefore reduce patient suffering. The National Wound Care Strategy provides clear recommendations in terms of how to care for a patient with a lower limb wound. But today's session is going to focus on that immediate and necessary care, as actually this is the bit that's been rather groundbreaking in the way that we are now managing lower limb wounds. So the first thing that the National Wound Care Strategy asks you to do is to assess for the red flags. And this is part of the immediate and necessary care. So this should be delivered by every practitioner. Doesn't matter who you are, what role you have, if that person presents to you with a lower limb wound, this is what you should be doing. And those red flags is about really trying to tease out, does that patient require urgent escalation to other services? So I just want to spend a few moments with you explaining and helping you recognise each one of these red flags. So the first red flag that the National Wound Care Strategy asks you to assess for is whether there is any acute infection on the leg or the foot. And the reason for this is that we really need to tease out any patients with active acute cellulitis or patients with foot ulceration with infection, especially diabetic patients. So actually the first red flag asks you to assess for any systemic features of infection, such as a raised temperature, a raised pulse, tachycardia, the patient feeling generally unwell, complaining of flu-like symptoms or a general malaise. These can be signs of a systemic infection. And then it's actually about focusing on the leg, thinking about whether there is any evidence of local infection. So thinking about, is there any evidence of redness, erythema around the wound margin or spreading up the limb? Often, if it is infective, there will be a clear demarcation between the normal looking skin and the inflamed skin. When you're thinking about cellulitis, you're looking at the wider part of the leg, looking if there is any changes in terms of the skin shape and size. And I say that in terms of its shape because it can start to look more like orange peel. As the subcutaneous tissue starts to get more inflamed, you actually get puckering from the hair follicles down into the dermis, so you get this like orange peel effect, and that can be a classic sign of having cellulitis. For many types of infection, that the patient will be expressing pain, which is worse actually on palpation or movement of that tissue. But just be careful with the diabetic patient because obviously their pain mechanism can be depleted because of their underlying neuropathy. It's about thinking, does that foot or that leg feel hot to touch? With infection, you often get heat. You get that edema, which makes the tissue look glossy, and actually you get an elimination of fine lines, and occasionally you can get blistering surrounding the wound. Or if you've got any presence of pus that's happening or discharging from the wound, especially of a patient that's got foot wounds, you need to be thinking about, is there any evidence of acute infection of the leg or the foot? And this is where you need to be referring those patients urgently back to their healthcare practitioner. That being their general practitioner, or if you're unable to get hold of that, that's escalating it further because actually acute infection is a medical emergency. And the reason why it is a medical emergency, it links back to the next red flag, because actually what we need you to do is to screen for signs of sepsis, because sepsis remains the number one killer of patients out there, and it is preventable, is that death. So it's about screening your patients for sepsis, thinking about those wider systemic responses. If that patient is reporting confusion, slurred speech, or is simply not making sense, think about that infection. If the patient's becoming more sleepy or difficult to rouse, again, it can be a sign of sepsis. You often find that patients, as they go through the sepsis, become relatively pale around the lips or around their fingers as it starts to impact on the oxygenation of the tissue. If your patient's got difficulty breathing, an substantially elevated temperature, pulse or respiration, and increasing breathlessness, you need to be thinking of sepsis. And if you have any signs of sepsis, this is an acute emergency and the patient needs to be directed to an accident and emergency department. So there are your two main signs, and actually presence of infection and sepsis can happen and does happen within the management of wound care. But the third red flag is actually looking for you to assess if a patient's got acute or chronic limb-threatening ischemia. Let me reassure you that acute ischemia, sudden onset limb ischemia, is very rare indeed. You're probably not going to see that within your professional career. So for an acute ischemia, patient would report a sudden onset of terrible pain, mottling of their skin, and that patient does need to be directed to accident and emergency. But like I said, that is rare. The other side of that, though, is chronic limb-threatening ischemia. So where we've got a reduction of the blood supply in the foot that's happened over a number of weeks. And that patient can develop arterial rest pain or gangrene of the toes, such as seen within these pictures. This isn't sudden onset. This has developed over a period of time and is often associated with severe pain, especially on a night time. But again, beware of your diabetic patients who may well be masking that pain. If patients are showing any signs of tissue loss on their feet, especially any areas of black gangrene, those patients need to be screened out for critical limb ischemia. This is not a medical emergency as such. The patient doesn't need to go to A&E today, but that patient certainly requires an urgent referral to the vascular team, and that patient should be seen within a matter of days. We try to ensure that patients are revascularised within a target time frame of 14 days. So we need these patients referring to us as soon as possible. So there's no need for an acute admission, but certainly a need for acute escalation. So that's the third red flag to watch out for. The fourth red flag that the National Wound Care Strategy asks you to assess for is whether you've got any suspicion of an underlying deep vein thrombosis. Within a deep vein thrombosis, the initial signs is often unilateral limb congestion or swelling, one leg. If you've got bilateral limb swelling, the chance of you having a deep vein thrombosis is very small indeed. The patients will often describe its sudden onset within the last 12 hours. 12 hours ago, my leg felt fine. I've woke up this morning. It's terribly painful, it's terribly swollen, and it's terribly inflamed. Patients often report that they have increased pain when flexing or extending the ankle joint. You can have some red or purple discoloration on the back of your leg, and it can be warmer to touch. But for me, when I'm thinking about as a patient got a potential to have a DVT, it's actually asking about that patient what's been happening over the last 2 weeks. Have they had an operation where they've been immobilised, which has increased their risk of having a DVT? Are they currently wearing a cast on the other leg, which again has impacted on their mobility? Have they got underlying thrombotic disorders or an underlying cancer, which makes them more likely to develop a DVT? And finally, has a patient been on a long-haul flight? But actually, the evidence about long-haul flights and developing DVT is getting weaker as the years go on. But it's about thinking about, has there been a recent change in that patient's mobility that could have increased that patient's susceptibility to develop a DVT? And then the final red flag is talking about if that patient has got suspected skin cancer. There's still many basal cell carcinomas and squamous cell carcinomas on the lower leg which we are missing. So if a patient reports a blemish or a mark on their leg that's changed over time, that's often itchy, it heals but then it bleeds again, have a suspicious in your mind about whether this could be an underlying skin cancer. Some patients report them being slightly painful, but most patients say they're tender and itchy. I think we all need to slightly reduce our tolerance of undertaking a wound biopsy, because actually that's the ultimate way that we can exclude any form of skin cancers. So they are your red flags. That's what the National Wound Care Strategy asks every clinician to assess for. And then following that, the National Wound Care Strategy finally gives a clear definition of what is a foot wound and what is a leg wound. They've actually drawn a line in the sand that links from the top of the foot round to the lateral malleolus. And you can now have clear recommendations in terms of whether that patient needs referring to a podiatrist or a wound nurse. So when we talk about the immediate and necessary care, it's about assessing for those red flags, but then actually it's about delivering some form of here and now wound care. What we've done is actually we've bring cleansing back. We need to ensure that we are cleansing the wound and the surrounding tissue with the most appropriate factor. We need to be putting on a dressing that's low adherent, that's not going to stick, but something with sufficient absorbency to control that level of exudate. But actually, the thing that's really groundbreaking from the National Wound Care Strategy is that we're now saying apply 20 millimetres of mercury pressure here and now, only on the exclusion of the red flags. There's no need to palpate pulses or to arrange an ABPI. We need to be putting on 20 millimetres of mercury straight after our red flag assessment. And that's because we think, and the National Wound Care Strategy supports, the fact that actually this compression can do very little harm. In fact, so long as you've screened out for your critical limb ischemias or other detrimental factors, then actually this compression can aid healing and therefore prevent that wound from deteriorating. So think about this as first aid for legs. So you need to think about within your practice of how you can deliver 20 milligrams of mercury pressure, and there's a number of ways to do that. And the reason why the National Wound Care Strategy is asking that is the fact that we need to be treating these patients sooner in the pathway. For every chronic wound that we are dealing with out there started as a small, simple ulcer. And if we were able to get their first aid compression right from the moment that they ulcerated, there is a chance that we could actually reduce the amount of chronic ulceration that the NHS is currently dealing with. The immediate and necessary care also highlights the need for onward referral. So it does clearly state that if you have a patient with a wound on their foot, they should be referred within 1 day to a multidisciplinary team. If you have a patient with a wound on their leg, there is 14 days from original presentation for you to complete that full holistic assessment, that ABPI, that underlying diagnosis. So we've tried to shorten the timeframes to really focus on that accurate diagnosis as soon as possible. The evidence base is relatively clear. We know how to heal a patient with a venous leg ulcer. And what we're trying to do with the National Wound Care Strategy is ensure that that evidence base is available to the patients there and then. And the major thing is about getting that patient into that strong compression as soon as possible. And that's why that 14-day challenge has been given, so we can get those patients into strong compression as soon as we can, because that is the best way to help manage a patient with a venous leg ulcer. We need to review these venous leg ulcers and think about them as a weed. We need to be thinking about that underlying venous hypertension, and the only way we can manage that is actually through strong compression. So we need to be thinking and changing our opinion of that venous leg ulcer. We need to not think about it as a wound on a lower leg. We actually need to think about it as a weed. What you're seeing is basically the head of the weed. We need to treat the underlying venous system, and we need to do that as soon as possible with strong compression. So hopefully this session has given you the requirements of what immediate and necessary care involves, and given you now the underlying knowledge and the confidence to be able to assess the red flags for your patients and therefore start that mild compression as soon as you can. Thank you for watching.